Hello, good evening, everyone. Thank you for joining tonight's webinar. We have a number of attendees. If you have any questions, we'll open the mic towards the end. I'd like to address today how to read dental bone loss when you obtain a CT scan using VetCAT on your patients. And we'll sort of go over some basics first, and then quickly go take a look at a few cases together. Just quickly, the VetCAT CT scan is a cone beam CT. It rotates around the patient. Just one rotation, it takes about 30 seconds. And then once the images are acquired, then the screen comes up, and there are various areas, various cuts of the patient, as you can see here on the screen. I want to take just a moment to go take a look at the human side of it, of things, just to point to a couple anatomic features that I think are interesting. And here on this slide, what you see is two types of extreme biotypes. That's how we classify it in the world of periodontics and dental disease. We look at patients roughly in two categories: the thick and flat patients that have very thick bone, their teeth, very square teeth, and the more thin and scalloped and delicate bone. And you'll see how that matters to us in just a second. So if we were to look at bone underneath this sort of tissues, the thick and flat patients have rather thicker bone. They'll have square teeth, but more importantly, they'll be bone almost to the cemento-enamel junction. And if I point to this, I think you can see here on the screen that this bone is thick and close to the CEJ, the enamel limit. Whereas on the thin and scalloped patients, we're not going to see this. We're going to see very delicate bone, very thin bone, and very often it will be away from the cemento-enamel junction, although this is normal and healthy. And that's really where the difference is. It's going to be important to recognize that this distance from the bone level to the CEJ varies from patient to patient, even in normal. So not the distance is not always a standard distance. We'll see more of this in a minute, but when it comes to bone level in 3 dimensions, then we can very clearly see the bone loss and bone topography around teeth. This is true on humans. And just a quick note on the fact that research has been done over the years to confirm that cone beam CT, in particular because of its high quality in resolution, is in fact accurate. So what we see, the sort of bone level and the measurements we can take on cone beam CT, which is represented here on the lower right quadrant, is in fact accurate. Those measurements have been verified. They are as good or better than regular radiography without the distortion. There is no distortion on cone beam CT because of the 3-dimensional aspect of it. So when we look at a cross-section of this particular patient here, this dog, we have to recognize what is normal. And we'll spend a bit more time in just a moment to recognize what normal should be. Here we see bone level on the buccal lingual aspect, something that we're not used to seeing in 2-dimensional radiography because we look at projections. So this is buccal, this is palatal or lingual. the bone level around teeth, particularly on the buccal aspect, can sometimes be difficult to see in very thin sort of types, but this would be a normal representation of bone level. Here on the lower, we actually see space. This is the normal periodontal ligament seen in a cross-section. So again, if we were to look at histology, we would be familiar with this. This is the dentin, cementum, the periodontal space, and that's the bone level. And as we can see here, the bone peak, but also is very thin in this sort of most coronal aspect of it. So this coronal bone is very thin. It usually is somewhat dense, but it can be very, very delicate to the point where it's difficult to see on a radiograph, and it's difficult to see on CT scanning, such as combined CT, because of the width of it. It also happens to be close to very dense tissues, such as the dentin and the cementum, and as a result, we might lose the image of it right at the tip of it. So here are two examples of some different biotypes. On the human side, we would call the left one thin and scallop. We would call the right biotype thick and flat. And I think you can all see the difference that the crest of bone on the buccal aspect of this dentition is very thick here and very much easier to recognize. This is normal, and so is the image on the right. Also, to recognize there's a distance between the crest of bone and the cemento-enamel junction, which we expect to be maybe 1.5 millimeter of a distance, but there can be some variation. And here on the palatal aspect of this particular tooth, we see a distance that's probably greater than what we can measure on the buccal aspect. So there is variation on the distance between the crest of bone and the cemento-enamel junction, and that is also within normal. Here's a cross-section of a young dog. We'll look at that CT scan again in just a moment, but I just want to sort of briefly show you what this cross-section means. The right side of the screen is buccal. The left side is palatal. And here again, we're looking at a cross-section of a normal anatomy, although it appears at first that there might be some bone loss. But just remember that this cross-section in the axial direction is at a level where bone is no longer visible, because we're cutting through the anatomy at a more coronal aspect of it. And in this canine tooth area, we might think that there is some sort of periodontal pockets on the palatal aspect of this canine, but in fact, we're actually looking at a cross-section that is more coronal than the bone level, the crest of bone. The way to know this is to look more carefully and recognize that we see enamel, meaning that we're more coronal than the cemental enamel junction. We're not at the root level, and we don't expect bone to be in contact of the enamel. So this is also normal. So again, with the VetCAT, we can diagnose, plan, and address treatments quickly. There's many users around the country. There's just a few pictures of them. And there's a lot of cases that have been documented so far. I just want to look at just a few cases with you. And we're going to jump to the VetCAT software now, and we're going to start looking at normal and advanced cases. So here, what are we looking at? We're looking at normal anatomy on the young patients. This is exactly the way this anatomy would be presenting itself as you are first scanning the patient. You can then zoom in and look at this more closely. A lot of times people will ask me, how do you first look at it? I like to look at the axial view first and sort of scroll through the anatomy from the nose to to the colon aspect of the patient, just to get a rough sense of the anatomy. But here I just want to stop at a couple spots and just show you what to expect when the anatomy is normal. And so if we sort of scroll through, we'll see a couple different situations. Here's again bone level on the buccal and on the palatal aspect of this particular tooth. And we'll notice that this buccal bone is somewhat thick, but we can see it pretty well. We can zoom in and we can measure the distance between the crest of bone and the cemento-enamel junction. And it might be around 1.5 to 2.5 millimeter. And again, this distance can vary from place to place. Remember that on a VetCAT, when you do this sort of measurements, this measurement is in fact accurate. So here's 1.6 millimeter from the crest of bone to the cemento-enamel junction. While we make our way through the dentition, we'll notice that this bone thickness might actually change from place to place. So if we quickly go to a more posterior portion of the mouth, we'll actually see that this bone, crest of bone on the buccal aspect is much thicker than it was just a moment ago. So this bone thickness varies within the patient as well. Now, like I mentioned earlier, as we move into other parts of the dentition, such as the canine here, now we're looking at a cross-section of the anatomy. It's a little different. This tooth is still erupting and forming. This buccal bone is very thin. In fact, it is so thin and so delicate that the crest of bone sort of becomes a little bit difficult to see. But that is also normal anatomy on this young patient. Let's take a look at what we expect in 3 dimensions. If we bring up the 3-dimensional image, enhanced image on the VetCAT, this is what we'll see. And this is, again, normal anatomy. Now, in 3 dimensions, it is interesting to look at this, and we'll look at more cases in just a moment. We do have to be a little careful about the 3-dimensional rendering because it's not as accurate an image as it would be on these various cuts. And so here we would think by looking at this 3D that there might be some bone loss and furcation exposure. So if I was to zoom in that root area, for instance, it appears that there might be bone loss to the point where there is maybe a class 2 or class 3 furcation. But we do have to be a little careful because 3D rendering in general is not the most accurate way to diagnose precisely. So if I actually sort of peel away the bone artificially by shifting the segmentation of this 3D rendering, I can make this situation look a lot more advanced than it actually is. In fact, it's to the point where we can uncover the roots and almost artificially sort of look at the roots independently from the bone level. So that is a little risky. If I go the other way, put the bone back into place, then now we see that the bone, in fact, is closing this furcation as expected in normal anatomy. So the 3-dimensional representation is a good way to look at disease in general, but we do have to be a little mindful of what it actually represents, and we should rely on the various cuts for precise diagnosis. We'll go on and look at a couple more cases together. Here's another patient, sort of also normal anatomy in a patient, a bit of an older patient this time. And here, again, this would be the way you would expect it to be right at the moment you scan the patient, literally about 40-50 seconds after the scan is completed. This time again, we see bone level that varies a little bit from area to area. We see this bone level here, for instance, if I was to zoom in that spot. And we make this image a little sharper so we can see it better. Here's the crest of bone. Here's the segmental enamel junction, the thickness of bone. This is normal anatomy. And if we move to different parts of the mouth, say this area right here, again, we'll recognize the buccal, the palatal. You see here the palatal aspect of this bone is pretty thick and easy to identify. Very short distance between the crest of bone and the enamel, enamel junction. This is also normal anatomy, no bone loss to notice here on this case. And we'll move on and take a look at this time a situation that presents with bone loss. And I want to show you here, as this is coming up, that we have very localized bone loss. How do we see this? Again, we start by this positioning of the patient, sort of scrolling through from the anterior portion to the caudal portion. And as soon as we do this, we start noticing bone loss on this anterior portion of the tooth, just this one area here. And let's take a closer look at this. If we have a bit of difficulty to notice this, one way to sort of quickly notice and point to bone loss in general is to look at the panoramic view. And how do we do this? We trace the arch. When we trace the arch, we can quickly see bone level all the way across in a rough way. This is not meant to be, again, a very precise diagnosis, but if there was significant bone loss, and in particular periradicular loss, where there would be class 2, class 3 furcations, we would see it very quickly. If we go back now to this, what we call this Npr view, and we scroll from the anterior portion of the mouth to the posterior portion of the mouth, we quickly notice significant bone loss around this one particular spot. So this is very localized. And if I zoom in by using this tool and sort of focus on this one portion of the tooth here, what do we see? We see bone level that should be on the mesial distal aspect, should be a lot more colon than it actually is. And on the cross-section aspect here, from the buccal to the palatal, we see significant bone loss. This is the crest of bone. This is the palatal crest of bone. And of course, here we have a significant distance between the crest of bone and the segmental enamel junction. If we have doubt and we're a bit lost in space initially, then we can certainly bring up the 3D again, being a little careful about what we actually see. But in 3D, we would in fact notice this significant amount of bone resorption in this one area. It becomes a bit more obvious in 3D. We also see that that tooth is displaced. And if we zoom more into this spot, we will actually start to recognize the shape of the bone loss. It's more of a flute-looking, significant two-wall defect in most of this around the tooth. So this is a one-wall, two-wall defect with complete bone loss on the buccal aspect. There would probably be some mobility as well, very localized. Otherwise, we don't see this sort of bone loss in other parts of the mouth. So if we go back again to the cross sections, while we're looking now at the coronal aspect of this anatomy, what do we see? We see from the most coronal to the most apical we see significant bone loss, and if we are wondering where the defect is, in fact, let's take a look more closely. We're looking at a cross-section of the tooth, sort of two-thirds apical on the root, and we notice significant bone loss on the buccal aspect, on the mesial aspect. We can also see this defect more clearly as we zoom in. We can change the contrast of it to make it a bit more obvious if we need to. But here is the defect on the mesial aspect, a wider periodontal ligament. That's due to the displacement of the tooth and probably some mobility. And as we make our way more, we now see a two-wall, one-wall defect. And finally, let's now look at a more advanced patient situation. And if we bring up the 3D on this patient, what do we notice? We can also utilize the 3D for a quick view of significant bone loss in general. Again, to be a little careful, of course, we notice at the mandibular right area, complete bone loss. One of these teeth, at least this one here, is only retained by soft tissue. There's really no bone to speak of in this very significant area. The bone level is actually sort of not equal across, of course, as expected. We can see that there are areas where the bone level appears to be quite normal in spite of significant bone loss in other areas. And now we see unique areas such as this spot here, for instance, where there is bone loss that causes a fenestration. It appears that there is buccal bone at a normal bone level, and yet we have this significant fenestration that seems to be a through and through. You can actually see right through it all the way to the other side. And we have to wonder how this took place, so we can then look at the cross-section and have a better understanding of it. So let's go take a look at the cross-sections now. These are on the side for a moment. And let's see how this case presents in the cross-sections. So this is how we would see it initially. We would then look at the patient from the anterior portion to the posterior portion, just sort of slowly scroll through the anatomy to give us a sense of the sort of pathology we're going to find. And when we do so, we'll see that some areas appear to be somewhat normal. Here's buccal bone, very thin, and yet the crest of bone seems to be close to the cemento-enamel junction. As we make our way back, we now see the significant bone loss that we notice on the 3D. Remember that the left is on our left in this particular view by convention on CT scan. And then we continue to scroll through. We notice some sort of normal-looking bone level. This appears to be normal, for example. This is just one area where we have crest of bone that appears to be at a normal distance from the CJ. And we make our way back. We're already sort of expecting a significant periodontal defect at some point. We make our way to the molars. We can see the endodontic canals. Bone level seems to be very thin on the buccal aspect of this tooth, but still within normal limits. And as we make our way back, we see a very significant bone loss that's very localized. We can see it in cross sections in all directions. On the coronal view, looking down at it, the defect is a sort of a wraparound on the mesial and palatal aspect. This is a two-wall, probably a three-wall defect as we get more apical to it. We can notice the communication to the palatal aspect of the tooth. As we move more closely into it, in the cross-section, we see that the bone loss is mostly centered around one of the roots. So now we have a buccal lingual view of a localized, significant, severe bone loss. We now know, as we could sort of anticipate from the 3D, we know that it's a through and through. It's going right from the buccal to the palatal if there was any doubt. We know that it's a wraparound in one of the roots at least. It's more significant on the palatal aspect than on the buccal aspect. All of the dimensions of these bony defects are very, very clear to us and relatively easy to identify. If we wanted to have a better feel for the sort of bone defect in other cuts, we can do this. We have many tools for this. This is just one of them, where we can do a cross-section of the tooth from the buccal to the palatal aspect of it. And when we do so, we're now looking at the very specific spot across the tooth. So this is buccal, this is palatal. The left side of the two-point oblique screen is buccal, the palatal is on our right. And we notice that the bone level in this particular spot is normal. It's actually very close to the CJ, whereas on the palatal aspect, the bone level is completely lost. We can measure that defect, as a matter of fact. From the crest of bone to the CJ, we now have 4.8, 4.9 millimeters. We also have an intra-bony defect that continues on. So if we were to measure this defect, we can do that too and measure another 4 millimeter. So if we now wanted to probe this, if we could, remember that the probe would probably sort of stop right there because of angulation. But we can look for that defect and go right from the CJ to the most apical portion of this defect, and we should measure the distance from the CJ to the bottom of that defect to about 8.7 millimeter. So this is quickly, in a nutshell, how to utilize three-dimensional radiography to diagnose bone periodontal disease in general and bone defects in particular in a very specific and very precise way. This can be documented and saved. For example, this measurement I just made is now saved to our records. So if I was to go back to the initial picture and I wanted to jump right back to what I just did, it's right there. We can actually sort of save that picture as well on the side, have it as documentation, and make a precise diagnosis for the future of this tooth, whether it's an extraction or, in this case, it would most likely be that way. But if there was a more reasonable defect, we could consider doing some sort of regeneration. This sort of technology now helps us clearly decide what we're dealing with way before we go into the surgery, at a point where we can make a decision prior to entering the procedure. I'd like to thank you all for your attention. I'm going to sort of unmute everyone. So if you type a note on the side or jump in and ask a question if you want to go ahead. I see there's a number of people here who are muted. So if you want to unmute your microphone, you'll be able to talk to the group. But you're quite significant. Thank you for your time. I'll be looking for questions. I think some people can probably type questions from the keyboard as well. I see one question here, which is, let me take a look here. A question here about furcation classification. I think some of you know this probably better than me. On the human side, as a periodontist, I can tell you that the classification we use, class 1, 2, and 3, furcation involvement, is really a clinical measurement. We use the neighbor's probe. Someone just a few days ago was asking me, what do you use? We use a neighbor's probe to measure for. This is a sort of a curved, angled probe specific for furcation measurements. And it's an interesting question because very often when we have a defect, even like this one, for instance, the probe would actually end short of going through. There is a bone peak. There's a bit of bone in the furcation area, at least in part. The probe itself, whether it's a some others, have a thickness to it. It's about 0.8 millimeter in thickness of the probe. So often you may or may not expect your probe to go right through this furcation. In fact, if we were to measure this crest of bone to the other side of the furcation, in this case we'd find about 1.8 millimeter, but it wouldn't take much triangulation to actually not be able to place the probe through and call this a class 1 or class 2 furcation. Whereas in fact, radiographically, it really is a class 3 furcation, as you can see on this image. I thank you for your time. This webinar is recorded. It will be posted on the internet within a few days, and you'll get a notification.
David, I have a question. It's Mary Hernandez.
Hello, Mary.
Hi. One of the things is, in practice, are most people doing the cone beam CT and then having them come back for the procedure?
In practice, what I've seen so far is most people actually, because of the speed of the imaging, will actually take the VetCAT scan and then go ahead with treatments. There are a few people who intake the patient in the morning. We'll do sedation. Remember that the patient has to be sedated, so some sort of lighter sedation, take the scan, do a diagnosis, present it to the owner within the same hour or so, or just the time they're done their treatment plan, and then go ahead with treatments that day or maybe just that shortly thereafter. But most people will will really image, diagnose, and treat all at once because of the convenience of having the patient under general anesthesia, ability to do the CT within about a minute or two, relatively quickly.
All right, I have one more question.
Yes.
What does calculus show up like on the cone beam CT?
Oh, yes. Actually, I think I had an example of that. I don't know that I can find it right at this second. Calculus shows very well. If I had some right now, I would show it to you. I just noticed some actually just earlier today. Calculus being so, it's actually going to look like, if you can picture this, it will look like the density of dentin. And you would know it's calculus because it wouldn't be where you expect dentin to be. You'd actually see as if you saw dentin that goes over the enamel. But it's that, so it's actually quite easy to see. And it's not, of course, it doesn't follow the anatomy of the dentin. So you'd sit sort of sitting on top of the enamel junction, right on top of the enamel in general. And you'd recognize this irregular shape. It will be very easy to see it because of its density. Yeah, that's an interesting question. Yes. I'll make sure to send you a picture as soon as I see it again, Mary.
Thank you.
Okay, thank you all for spending a little time with us at this late hour of the day. And again, this webinar will be posted on the internet next week for those who couldn't make it or came in late and would like to catch the beginning of it. You'll have a full recording probably early next week. Thank you.